المحاضرة الجاية بعنوان Integrating Artificial Intelligence in Point of Care Ultrasound. Does it make a difference? أهلا بيك دكتور أشرف.
السلام عليكم. Thank you very much, Dr. Ahmed and Dr. Magid. And again, thank you very much for the scientific committee for giving me this opportunity. Actually, maybe it's so sophisticated to talk about artificial intelligence in critical care ultrasonography if the human, you know how to feed this machine with the needed data. In the fluid responsiveness, which is a common question every day, the same can be applied. VTI variation or peak velocity variation. If I have a number of the velocity time integral, the area under the curve, in inspiration compared to expiration with a number above 14%, this is VTI variation that variate the hemodynamics, variate with the change in the respiratory pattern and the change of the cycle of respiration. This is also can be taken very cautiously because you have to teach the machine that this is the time of inspiration, this is the time of expiration, and the machine will calculate for you if there is variation or not in the peak velocity and on the VTI itself. IVC is commonly used, but the machine, unfortunately, has to be taught also that the IVC identification has to follow certain rules, which is I have to see a pipe or tube that opens into the right atrium and with a another small channel, which is the hepatic vein draining into the IVC. Otherwise, the machine might recognize the descending aorta as IVC. And it gives you the data from the descending aorta. So human here is very essential. You and me has to know that this is IVC. And again, easy things to do. And once you get it for the machine will automatically find from inner wall to inner wall that this is the IVC size. This is when it collapses. This is the difference between the maximum size and the minimum size. And it gives you calculation of collapsibility index. Collapsibility index of 12%, 15%. It has to be more than 15% to be very straightforward, answering that patient needs fluid. Otherwise, the gray zone between 20% to less than 50%, nobody knows if patient is fluid responsive or not. But the artificial intelligence can help you if you have a good image to identify and do the measurement for you, and this is may save times in ICU. When this was compared to the human expert-focused human people, doctors working in ICU, were compared to deep learned machine, if they are equal or not. In the majority of these studies, there was no difference if you teach the machine how to recognize things. So the machine can give you the job without going and doing sophisticated measurement. But again, you are the determinant of the study. You are doing the study, and the machine is going to apply the principles and give you the calculation, and that's it. One of the issues that we face every day in ICU, I'm forgetting actually, unfortunately, is assessing our patient's heart to know if they are heart failure and what type of heart failure, especially in the time of weaning from mechanical ventilation, because we know the weaning induces heart failure. And the weaning induces heart failure might be systolic or diastolic, with reduced ejection fraction or with preserved ejection fraction. And we have a lot of controversy here where to fire the M mode. And if I fire the M mode on the parasternal long over an area of reduced wall expansion or with regional wall motion abnormality, my patient's ejection fraction will be low. And vice versa, if you fire the M mode over area which is hyperdynamic, the ejection fraction will be higher than what is there in reality. So ejection fraction cannot be equal to cardiac output. You have to put this in mind if you rely on cardiologists, for example, to give you this study or this examination, because they are not bedside and they are not aware of this. Again, weaning-induced pulmonary edema is known and not uncommon in ICU. And one of these factors might be because of low systolic function or impaired diastolic function. There are a lot of evidence nowadays, small though evidence, that when you teach the machine to know that this is the time of systole, when both walls goes approximating toward each other, this is systole. And when it goes away, this is diastole. And then the machine will lineate the endocardium automatically and tell you the volume during systole was this, and during diastole was this. And then with marked improvement in estimation of ejection fraction, subtracting the systole from diastole, dividing in diastole will give you the ejection fraction. This was found to be more accurate than what we do bedside, especially in our critical ill patient. But again, you have to give the machine a good image with good delineation of the endocardium. Otherwise, the machine will read for you a wrong and give you a wrong information. This was tested in the COVID patients. And during the COVID time, we were very afraid to come closer to patients for a long time, and we shortened the time to come in contact with patients to as much as we can. The AI in this time was found to be beneficial because you can just feed the machine with images and you go away and the machine will give you the information. Applied also to diastolic function assessment in critical ill patients to know E to A ratio and E to A prime, and the machine will give you these numbers very carefully. When combination of this, the VTI and E level and E to A prime was all combined together, they put a score. If you have this score, the machine will tell you that the score of the IVC collapsibility plus the score of VTI times this number plus the E, which is an indicator of the filling of the left ventricle. If it is more than 50, you have fluid responsiveness because of these parameters. So it can give you a lot of things. Ladies and gentlemen, as I mentioned, life is not easy in ICU, and there are a lot of helpful tools to assess your patient's heart. And we have to put in mind that this is essential in critical ill patients because cardiovascular compromise is not only in cardiac patients. Most of the things that we are facing in ICU can compromise the heart, right and left. Sepsis is not the only one among them, but the mechanical ventilation, initiation of mechanical ventilation. A lot of drugs that induces cardiomyopathy, a lot of things can affect badly the heart. And you have to know with ease how to assess this patient's heart. And believe me, blaming the heart for any deterioration of the clinical condition is considered to be a right way to reach a diagnosis. So for any patient who is tachycardia, don't ignore that this tachycardia is not only because of pain or asynchrony with the mechanical ventilation or anxiety, it might be because of heart failure. Despite this patient might be admitted with no heart failure, but he or she developed heart failure. There are tools that are easy to do bedside. One of them is to see how far it goes, the anterior mitral valve leaflet compared to the septum during the opening of the valve. We call it the EPSS, the eight-point septal separation. Just open the mitral valve in the parasternal lung, and you fire the M mode at the tip of this mitral valve, at the tip, not at the leaflet itself. Then you can have measurement that can help you. The TAPSI and MAPSI, the excursion of the annulus of both tricuspid and mitral valve, are very helpful and correlating very well with the systolic function when it was tested compared to other tools to assess the systolic function. They are very helpful and easy to learn and easy to do bedside. And again, the artificial intelligence can be very helpful here. There are a lot of kits of tools. Use the artificial intelligence. And there are a lot of things out of the heart that found to be also very beneficial, like the lung. When we have the lung, we can diagnose, as I mentioned this morning, that this lung is wet or dry. This makes a lot of difference in fluid therapy. That when you see a vertical lines moving with the pleural line, and do not see with them vertical, horizontal line, which are A lines, and the end by the screen bottom. These are the definition of B lines. And B lines, when they are more than in one space, more than two, it indicates increase in the extravascular lung water. So this lung is in pulmonary edema, either cardiogenic or non-cardiogenic. And you can, by looking at the pleura, which you see here, this is the pleura. When you look at the pleura and you find it unhealthy, not shiny, not smooth, not very smooth, and moves very clear, not corrugated and interrupted. If you see abnormal pleura with this extensive B line, this is not cardiogenic pulmonary edema. This is non-cardiogenic pulmonary edema, or ARDS. And then the difficult question is how I identify if this is true or false B line with the criteria I mentioned. You have to recognize them with your eyeballing. But if you teach the machine how to identify true B line, the machine can tell you that in this space you have more than 2 B lines, and this is a wet area, and this was found to be beneficial by small studies, though a lot of studies to indicate that artificial intelligence in lung identifying if the lung is containing extra amount of fluid or not. This was found also for pleural effusion, for consolidation, for collapse, for everything you look to see in the lung bedside using the ultrasound. Using artificial intelligence saved a lot of time and taught junior people in ICU, if they know how to handle the probe, know where to put the probe, and then the machine can help in teaching them that this is true B line. This area is wet, this area is dry, this pleura is matching with this ARDS picture or not. There are a lot of tools, and the discrepancy between the expert when they use their eyes and their principles compared to deep learning machine, it was found that the discrepancy was found in less than 10% of the cases, i.e., if you feed the machine with the right images, the machine can help you. There is no doubt in this. And this was found to help more teaching and more education among junior staff in ICU, like resident and young fellows. This is very important, and you have to put in mind again and again that there is nothing to replace the human being. There is none to replace our rule in ICU. And do not please allow anyone to kick you out of ICU, because I'm afraid if a day will come and the machines will walk around and there will be no need for the physician, for a human being. But till we have this time, I don't think this will come to the artificial intelligence and ultrasound, because we need the human being to handle the probe, to know what they are dealing with. And believe me, up to now, we don't need this technology in ICU if we use our adapted eyes to the abnormalities and normalities. We have to teach our colleagues how to use their eyeballing, because you don't need much to recognize that this ventricle you are seeing here is collapsing and the walls are kissing, and this is fitting in the scenario of hypovolemia. You wait for nothing to give boluses of IV fluid. Adapt your eye to know and to identify if the heart is behaving like what you see in front of your eyes now, is known as a cardiogenic shock, because the heart doesn't pump much blood out of it. And then what you need here is to fit it into the context of clinical presentation, and you choose to go with inotropes. There is no much needed to see how elephant it is, the IVC in this example here, and how intermediate it is on the right there, and how small it is and collapsing much at the bottom here, to identify that the main pipe in this patient's body is empty or full and doesn't need fluid. Ladies and gentlemen, we have to use our eyes, and we have to keep teaching our colleagues and to raise the importance everywhere about using the critical care ultrasound bedside, regardless of what way you are using it, but you have to know how to use it, apply it, because this will save life. And by here, thank you very much.
Any questions؟ أي أسئلة يا جماعة؟ Any questions؟
هو موضوع رخم انا عارف يعني هو محتاج ان يعني the people has to come to the journey as early as possible if they are not yet starting. اتفضل.
بشكر حضرتك على المحاضرة طبعا، وأنا متعود على إن أنا أحضر محاضرات حضرتك، يعني مستفيد منها دايما. أنا يعني ليا كومنت يعني إيجابي جدا على البيت سايد ألترا ساوند، وإن جنرال على شغل العناية عامة يعني. لأن هو في فكرة العنايات المتخصصة عاملة يعني نوع من بتقدم خدمة في اتجاه معين. الخدمة دي كويسة جدا في الاتجاه اللي هي فيه، يعني مثلا كعناية كارديولوجي، كعناية صدر، كعناية صدمات. كل ده كلام كويس ان يكون في عنايات متخصصه. وانا يعني ام ريسبيراتوري يعني بيزيكالي يعني. لكن للاسف الشديد بعض العنايات المتخصصه بتحس ان ايه، ان كل فيما عدا التخصص بتاعها هو اواي من شغل العنايه. يعني مثلا تبقى في عنايات كارديولوجي مثلا تلاقي الدكتورز فيري ريلاكتنت ان هم يتعلموا بيت سايد الترا ساوند. فانا اقول موقف بس بسيط في لحظه يعني لزمايلي. كان في حد يعني شخصيه معينه دخلت بكارديوجينيك بالمونري اديما محترمه. الاكس راي طبعا كارديوجينيك بالمونري اديما ما فيهاش اي نوع من الجدل خالص. الراجل يعني صوره واضحه خالص يعني. القصه يعني جينا نفحصه بالالترا ساوند بيت سايد لانه ريكومندد. تمام. فده كان سبب الفحص يعني مش استدعاء رسمي. تمام، لانه ريكومندد يعني. ففوجئنا مش بي لاينز بقى، اير برونكوجرام جامد جدا جدا جدا، وسيفير نيمونيا بالسونار. لكن الاكس راي ما بتقولش حاجه. الاكس راي بتقول هوموجينس اوباسيتي بايلاترال وبيري هايلر وتمام التمام. والراجل فعلا اورثوبنيك، والايجكشن فراكشن بتاعه كان اراوند 21% و22% انه اكيوت مايوكاردال انفاركشن. لكن السونار كشف ان في سيفير نيمونيا. حتى احنا بعد ما قلنا لهم على فكره ده في سيفير نيمونيا، حد قال لك يعني ده جايين ياخدوا اللقطه، وكما لو كان المريض لقطات وحاجات زي كده. قال لك ده كارديوجينيك، يا مس اديله لازكس، يا مس اديله لازكس وشوف اللي هيحصل. تمام. واحنا واقفين طلع التي ال سي كان اول يوم 8. تمام. جابوا التي ال سي طلع 21 والبروكال بتاعه طلع 5. فيعني تو اكستنت ان البيت سايد الترا ساوند حتى في الحالات اللي انت ممكن تظنها ان هي ستريت فورورد وان هي ماشيه معاك تمام التمام، ممكن يقاد زي ما استاذ الدكتور اشرف قال يعني اضافه بالنسبه للمريض حاجه ما يعني فعلا ملهاش حل. اما بقى بالنسبه للفلويد ريسبونسفنس حتى لو الواحد يتعلم على قد ما يقدر، يعني مش عارف اتعلم ده، اتعلم الاي في سي في الاول بعد كده حط ايدك. انا بكلمك كحد يعني عجوز شويه. تمام. في فتره من الفترات لما جيت يعني اتعلم جديد مثلا من كام سنه كده، كنت حاسس ان دي حاجه ميراكل وان دي ناس ليها قدرات خاصه وما فيش داعي انك تدور يعني. لكن لما بنحاول بنجيب حاجه كويسه يعني. فانا بشكركم على المؤتمر طبعا مبدئيا
شكرا.
كفرع ريسبيراتوري يعني، ومتشكر جدا.
شكرا لحضرتك.
شكرا.